Thank you. So, dear Professor De Boer and Professor Mills, dear colleagues, thank you very much for the opportunity to be here. And I'm going to talk today about the guidelines adherence to statin therapy and association with major adverse cardiac events and perioperative myocardial injury. As you probably all know, and you can see here on the picture on the right, statins inhibit the HMG coenzyme A reductase and thereby reduce the synthesis of cholesterol in the liver. This leads to an increased expression of LDL receptors on hepatocytes, and LDL uptake from blood is increased and plasma levels is decreased. Statins are widely used for the prevention of coronary artery disease and associated secondary cardiovascular complications. Now, despite established evidence in acute and chronic cardiovascular disease, the optimal perioperative use of statins still remains uncertain. And current ESC guidelines, as you can see here on the left on non-cardiac surgery, limit their recommendation to the continuation of an already established statin therapy and to a possible initiation of statin therapy in patients undergoing vascular surgery. Data from pilot studies showed potential beneficial effects of statins on postoperative cardiovascular outcomes. So now, considering the high annual volume of surgery and the high incidence of cardiovascular events after non-cardiac surgery, potential beneficial effect of statins could translate into big improvements in perioperative care and population morbidity. Therefore, with this study, we aim to evaluate the current use of statins in patients undergoing non-cardiac surgery and to evaluate the association of statin intake with the occurrence of cardiac complications after non-cardiac surgery. We included consecutive patients undergoing non-cardiac surgery at the University Hospital in Basel and the Cantonal Hospital Aarau in Switzerland that received surveillance for major cardiac complications and cardiac PMI. Indications for statin use were derived from clinical practice guidelines by the European Society of Cardiology, and we chose to only include Class 1 recommendations for this analysis. We defined MACE as a composite of cardiovascular death and spontaneous myocardial infarction within 120 days after surgery, and as our secondary endpoint, we defined PMI due to cardiac causes such as type 1 MI, tachyarrhythmia, acute heart failure, or type 2 MI within 3 days after surgery. For the prognosis analysis of this study, we used inverse probability of treatment weighting to account for differences in measured baseline covariates between statin and non-statin users. This is a propensity score-based method to reduce the effect of confounding when using observational data to estimate treatment effects. We then performed univariable Cox hazard model with MACE and univariable logistic regression model with cardiac PMI as endpoints. Between 2014 and 2018, we included 8,116 patients for this analysis, of which 4,227 had a Class 1 indication for statin therapy. Here on the right, you can see an excerpt of Table 1 with only the patient that had a Class 1 indication for statin therapy, and they are stratified by their actual statin intake. On the left, you can see patients not taking statins, and on the right, patients that received statin therapy. And you can see that those patients receiving statin therapy were in general a little bit younger and much less frequently female, with only about 30% of female patients receiving appropriate statin therapy. Furthermore, they had more cardiovascular comorbidities, and they were taking more preoperative medication targeting cardiovascular diseases. From the patients that had any Class 1 indication for statin therapy, only about 58% received statins preoperatively. As you can see here on the graph, the more indications for statin therapy that were present, the more often patients received statin therapy. Usage was highest in patients with CAD and prior MI, and usage was lowest in patients with chronic kidney disease stage 3 to 5. Now, during our follow-up of 120 days, 161 MACE occurred, and here we can see a cumulative event curve of the composite MACE endpoint. And as you can see, the patients not receiving statin therapy, here in red, despite an indication for statin therapy, reach the endpoint more often than patients receiving statin therapy, here in green. And this resulted in a weighted hazard ratio of 0.66. Furthermore, 562 cardiac PMIs occurred, and despite waiting, patients receiving statin therapy had more cardiac PMI than patients not receiving statin therapy, albeit resulting in a weighted odds ratio of 1.12, albeit not significant. And this surprising result might be explained by residual confounding and for sure needs further research. Some limitations need to be considered. We cannot comment on statin indication from primary prevention due to elevated LDL levels. Furthermore, information on the duration of statin intake prior to surgery and the adherence to statin therapy after surgery was not assessed. And this is data from an observational cohort study. So let me summarize the last few minutes. Guideline adherence to class 1 recommended statin therapy was low in our cohort, and it was highest for patients with coronary artery disease and prior MI, and lowest for patients with chronic kidney disease stage 3 to 5. We saw that patients with class 1 indication for statin therapy and receiving statins had less MACE within 120 days, but more cardiac PMI than patients not receiving statin therapy. So we suggest that the need to undergo non-cardiac surgery could provide an optimal checkpoint to screen for appropriate statin therapy in patients. Thank you for your attention.
So, very nice presentation.
Yes, great presentation. I really enjoyed that. Really, of course, coming up on this conclusion that there is an increase in number of myocardial infarction in patients taking statin. Do you think that should be possible in this chronic patient taking statin to monitoring some biomarkers? Of course, I'm thinking about high-sensitive troponin as a target that can reverse. So we know that some patients with coronary artery disease, they can have some small increase in circulating high-sensitive troponin. If you add this in the future, should you revert this trend in order to targeting better the treatment of statins on high-sensitive troponin? I know that was not your target, but what do you think about this?
Sorry, can you elaborate more? I didn't understand the
So
question.
we know that in patients with chronic coronary disease, or like you said, we have a little small increase in high-sensitive troponin that you did analyze in this study. And you found that in these patients, there was, nevertheless, of using statin, an increase in PMI, right? My question is, should we be targeting high-sensitive troponin as effect positive of statin? If you have not this effect, you should increase statin, and the target will be high-sensitive troponin to prevent myocardial infarction.
I don't...
I think one of the issues that is being raised is reverse causality. So the fact that the group on statins are more likely to have perioperative myocardial injury might just be that they're the highest risk because they've got pre-existing coronary disease and raised troponins as a consequence of that. Do you think that's possible?
For sure, the patients that have PMI, they are usually more sick patients, but actually we adjusted for these comorbidities with the inverse probability of treatment weighting. So I don't really know. Maybe there are some other factors that we did not consider yet that play a role in why they had more PMI despite getting statins.
And just a follow-up question about the quality of surgical care in Switzerland. What's going on here? Why are only 70% of people with known coronary disease on a statin? prior to surgery. And I wonder if you could dig into it by looking at the type of operation. Maybe some of your surgeons are more likely to, document or prescribe or make sure patients are on appropriate preventative treatment.
That's a good question. So I don't think we can only look at the surgeons here, because I think there's probably many players that play a role in patients getting statins, or then maybe also I think that patients that probably had an event very long time ago, they probably have less statins, and we actually want to look at this, but we didn't have time yet to look at this. Yeah.
So we shouldn't start statins pre-op just yet, but it's interesting data. Thank you very much. We should, in the interest of time, move on.